Welcome to the GI Hepatology Academy presented by Harvard Medical School. My name is Dr. Sanjeev Chopra, and you are tuned into the live broadcast of Gastroenterology in the 21st Century, Optimizing Patient Outcomes. Dr. Lamont and I are pleased to serve as chairs of the first GI Hepatology Academy program. Today we will be talking about a number of interesting topics in hepatology and gastroenterology. And it is now my privilege to introduce to you the next speaker, Dr. Adam Chaffetz. Dr. Adam Chaffetz is going to talk about inflammatory bowel disease, what every clinician needs to know. Dr. Chaffetz is the director of the Center for Inflammatory Bowel Disease at Beth Israel Deaconess Medical Center and serves as an assistant professor of medicine at Harvard Medical School. Before we get started, I would like to remind our audience that we will begin by taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. I'd now like to invite Dr. Adam Chaffetz to give his talk. Welcome, Dr. Chaffetz.
Thank you, Sanjeev. So what I'd like to do today is, so we're all on the same page, go over a brief review of inflammatory bowel disease, epidemiology, some of the features of it, what distinguishes Crohn's and ulcerative colitis, before we get into some of the complications and special situations you may see in the office. And then I'd like to try to get to the management and current treatment strategies for the treatment of IBD, as they're really changing almost on a weekly basis these days. So idiopathic inflammatory bowel disease is really broken down to two main diseases at this time: Crohn's disease and ulcerative colitis. There are a number of other colitides that technically fall under idiopathic IBD, although they'll go beyond the scope of this lecture. So IBD is not an uncommon disease. It affects more than 1.2 million people in the United States alone, pretty equally divided between ulcerative colitis and Crohn's disease. There's about 10,000 new cases diagnosed annually. The incidence of ulcerative colitis is flat over the last number of years, whereas Crohn's disease seemingly is increasing, particularly in the more developing world. It can affect patients at any age, although it is most common in young people, late adolescence, early adulthood. Median age of onset is 30. About 1/4 of patients are actually diagnosed as a teenager or younger. It doesn't discriminate between males and females. It's pretty even. Ulcerative colitis is the more simple of the two diseases to think about. It's mucosal. It starts in the rectum and works its way up in a continuous manner throughout the colon. It presents, almost all patients will present with rectal bleeding, a little more severe bloody diarrhea, abdominal cramps. They can get tenesmus and urgency. As the disease is more extensive, you can get some systemic manifestations, low-grade temperatures. The disease is characterized by flares and remissions. Most patients in the community will actually present with more distal and more mild to moderate disease. Over the course of the disease, anywhere between 10 and 30% of patients will require a colectomy. Crohn's disease is the more complex of the two diseases. It can actually affect anywhere in the GI tract. Typically does spare the rectum and is characterized by skip lesions or areas of affected areas right next to areas of sparing. Probably the most important thing about Crohn's disease is its transmural nature. It's the transmural nature of the disease that leads to the various presentations. You can see here, most patients actually present with inflammatory disease, abdominal pain, diarrhea, nausea, and vomiting. But over the course of the disease, it becomes more stricturing and particularly penetrating. Patients with stricturing disease can present with partial small bowel obstruction, severe abdominal pain, nausea, and vomiting. Penetrating disease can present acutely, like an acute appendicitis-like presentation, or it can present with fevers and findings of an intra-abdominal abscesses, as well as intracutaneous fistula, fistula to the bladder as well. Like ulcerative colitis, the course of Crohn's disease tends to be fluctuating between flares and remissions. Unfortunately, with Crohn's disease, upwards of 80% of Crohn's disease will require surgery over their lifetime, and a lot of these patients will have it within the first 5 years. Unfortunately, Crohn's disease is not cured by surgery. You can see here that about 50% of patients after surgery will have a recurrence of symptoms by 5 years, and by 10 years, about 10 to 30% of patients will already have a second surgery. The differential diagnosis of ulcerative colitis is quite broad. You can imagine anything that presents with bloody diarrhea. Even worse is the differential diagnosis for Crohn's disease. I consider it one of the great mimickers. Crohn's can present in almost any way, and you really have to think about all these different diseases. And particularly important in patients with Crohn's disease to not forget that they can have any of these other diagnoses complicating their disease. The diagnosis of Crohn's and ulcerative colitis is really a clinical diagnosis. It's a good history, physical exam, looking for some of the things that can potentially trigger inflammatory bowel disease, NSAIDs, antibiotics. You want to rule out any infections, travel. Smoking is a risk factor for Crohn's disease, where interestingly it's actually protective for ulcerative colitis. You want to ask about a family history of inflammatory bowel disease, though only about 20% of patients will have a first-degree relative with it. And on physical, you're doing a good abdominal exam, looking for any masses, obvious tenderness, and perianal disease. You want to look for fissures, fistula. Patients with Crohn's disease can get these large skin tags, and you always want to be cognizant of the extraintestinal manifestations. Again, the diagnosis is clinical. Labs, you can see anemia, you can see elevated platelets, other inflammatory markers, C-reactive protein can be elevated, though these are nonspecific. You want to get stool studies to rule out enteric infection. And I guess thankfully for gastroenterologists, the diagnosis, though, really requires endoscopy and in most cases radiology as well. Again, you want to look for triggers of IBD when they're seeing you in the office. You never want to assume a patient with underlying IBD that's having symptoms are due to a flare. You always want to rule out infection as well. So this is colonoscopy is really what's going to make the diagnosis. Ulcerative colitis, you can see here, is very diffuse mucosal changes, whereas Crohn's disease has more focal lesions. The picture in the top left, you can really see the aphthous ulcerations on a background of more normal mucosa. You can see linear ulcerations in the bottom right. Histopathology is really confirmatory and not diagnostic. This is a normal colon and normal pathology, and you can compare that to ulcerative colitis, where you really see a lot of really blue, which is inflammatory infiltrate. You can see the crypts don't make it to the bottom. There's a basal lymphoplasmacytosis. You can see crypt branching and crypt abscesses. Again, here's normal, and this is Crohn's disease. Again, more confirmatory than anything else. It looks very similar. The so-called non-caseating granulomas are rarely seen in typically no more than 20% of biopsy specimens. Radiology is typically used to look at the small bowel to find if it's involved or not. It used to be a lot of small bowel barium series. Now we're moving towards more advanced MR enterographies and CT enterographies. They do a great job defining the luminal disease as well as extraluminal complications. And here you can see a phlegmon with a central abscess. Capsule endoscopy, I don't typically use for inflammatory bowel disease. It's a little bit too sensitive and not specific. In addition, patients with Crohn's are more likely to have capsule retentions. Extraintestinal.
Adam, I wanted to ask you a question that one of our viewers is asking, and before you get into extraintestinal manifestations. And the question relates, it's by Dr. Margaret Malloy, and she's asking, in the blood workup, should every patient be tested for celiac sprue?
I typically don't test all my patients for celiac sprue. No, particularly, ulcerative colitis, like I said, it's going to present with bloody diarrhea. That's not going to be your typical presentation at all for celiac disease. Crohn's patients, I will often send, even in my Crohn's patients, a TTG and an IgA if they're having symptoms and I can't necessarily explain it by what I'm seeing on my objective evidence.
Right. So explain TTG antibody and why an IgA? Because some patients are IgA deficient.
Yes, so TTG, tissue transglutaminase antibody, is an IgA antibody. It's really the best test we have for celiac disease, but patients with IgA deficiency won't mount a TTG, and in fact, patients with IgA deficiency are actually more likely to develop or more likely to have celiac disease. So on to the extraintestinals. I think these are very important to remember. About 40% of patients can have extraintestinals. About 10% will actually present with extraintestinal manifestations, so they're not coming to their gastroenterologist, they're coming to their primary care physician or a specialist with complaints. Most common are the rheumatologic complaints, but the dermatologic eye complaints are also not that uncommon. And it's important to keep these in mind, and we often differentiate them between which extraintestinals go along with the course of the disease and which extraintestinals sort of march to the beat of their own drummer regardless of what the IBD is doing. One thing we don't want to forget is that patients with IBD, it is a hypercoagulable state, so these patients are at higher risk for DVTs, and this is particularly important in the hospitalized patients as well. One other thing I want to point out is that there's a number of studies that suggest that patients with underlying IBD in clinical remission when exposed to nonspecific NSAIDs have about a 20 to 25% risk of relapsing. And this isn't nonspecific GI complaints from NSAIDs. This is significant flare of the disease, and a third of the patients required steroids. There's pretty good data, one randomized controlled trial that COX-2 specific NSAIDs, in this case celecoxib, and low-dose aspirin are safe, at least in the short term, and acetaminophen is safe for patients with otherwise discomfort. I won't go into all the complications, but patients with Crohn's disease in particular are at a risk for a number of complications you can see listed here. I will go more into detail about colon cancer. Both patients with Crohn's and ulcerative colitis are at risk for higher risk for colon cancer, as well as osteopenia and osteoporosis. I know Dan just lectured, he mentioned this. Patients with IBD are at a higher risk for colon cancer, lower than we used to think it is. It's really probably only about 2 or 3 times that of the general population, although it does occur at a younger age. And it is the same for Crohn's and ulcerative colitis as long as the same amount of colon is involved. These are the risk factors in addition to just having the disease. The biggest risk factor is primary sclerosing cholangitis. These patients require surveillance colonoscopy starting 8 years after either symptoms or diagnosis, and then depending on the risk factors, they'll go on to get these every 1 to 3 years. Patients with PSC are special in that as soon as you make the diagnosis of PSC, they should get a colonoscopy to find if they have colonic involvement, and those patients get yearly colonoscopies from that point on because of the higher risk.
Adam, there's another question as we're moving on to osteopenia. Can Crohn's disease and ulcerative colitis, and this is from Dr. Carlos Rosario Martinez, can they coexist in the same patient? Have you ever seen Crohn's and UC in the same patient?
We wouldn't say they coexist. We have seen some patients where we thought had ulcerative colitis go on to develop more manifestations of Crohn's disease, either upper GI involvement, or after, typically we can see this after a patient with ulcerative colitis has surgery, gets an ileal pouch anal anastomosis, and those patients can then go on to develop fistulizing disease. About 3 to 5% of patients will have a change in diagnosis, but I can't say that they exist at the same time. That being said, to be honest with you, we're probably really not dealing with two diseases. It's probably just not Crohn's disease and ulcerative colitis. I think probably 10 years from now, we're going to have IBD 1 through 10, and based on different serologic markers and different genetic markers, we'll have a better idea of what diseases we're dealing with.
And within the same family, do you sometimes see patients, one sibling with Crohn's, another one with ulcerative colitis?
Yes, oftentimes the disease is concordant, but we definitely see families where some will have Crohn's and some will have ulcerative colitis. And then stepping back, about 10-15% of patients, regardless of how much workup we do, we can't decide whether this is Crohn's or ulcerative colitis, and we label them as an indeterminate colitis or IBD unspecified.
Thank you.
Again, osteopenia, osteoporosis is really not uncommon. Up to 50% of patients can have osteopenia, and it's clinically significant because these patients with IBD are at a higher risk for fracture according to a number of studies. The risk factors, for the most part, are the same as the general population, but in particular, active inflammatory bowel disease, particularly Crohn's disease, can have an effect on the bones themselves based probably on IL-6 levels. If we don't look for it, we're not going to find it. So who should have a bone density? Postmenopausal women, men aged greater than 50, and anybody who's been exposed to corticosteroids really for 8 weeks or more in my book, and according to guidelines, should have a bone density. Once you figure out they have osteopenia and osteoporosis, then we let others sort of treat, but I make sure they're really followed closely after that. I recommend calcium and vitamin D for all my patients. Another thing that I talk to all my patients about and put in all my notes to referring physicians is vaccinations. Patients with inflammatory bowel disease are oftentimes on immunosuppressives or soon to be on immunosuppressives, so we want to make sure any preventable disease is sort of taken care of ahead of time. I recommend yearly flu vaccines for all my patients, pneumococcus, Tdap, hepatitis B. Is important, not that just because we want them vaccinated, but we need to check the status before any anti-TNF therapy, and we'll talk more about that later. We want to make sure that the young people are vaccinated against HPV, meningococcus in the right situation, as well as hepatitis A. I always ask my patients when they first come in if they had chickenpox as a kid or the varicella vaccine. If they have not, I'll check a titer. If that's negative, I'll have them have the varicella vaccine. If they're not immunocompromised or soon to be immunocompromised, right now it's best to avoid live vaccines in immunocompromised. I think that's going to change over the next few years, but for now, it's the sort of simplest way to think about it.
So before you get into management, there are a few other questions related to epidemiology and risk factors and complications. Here's one from Dr. Kimberly Beavers. Should patients with PSC have screening colonoscopies at more frequent intervals than the routine risk colon cancer population?
Patients with
primary sclerosing cholangitis. more frequent colonoscopies looking for colon cancer?
So if they have PSC and known concomitant ulcerative colitis or Crohn's colitis, they get them every year. If the patients don't have a concomitant colitis, then I'm not sure what the recommendation is now. Actually, I'm going to ask Sanjeev whether they should have colonoscopies more frequently looking for the development of colitis because they are more prone to have ulcerative colitis or Crohn's colitis. But I think in general they're not more prone to colon cancer unless they have the colitis that's associated with it. So now getting into what I do on a very daily basis, what are the goals of care for inflammatory bowel disease? And these are changing. These are rapidly evolving. Clearly, once we make a diagnosis, and this hasn't changed, we really want to induce remission, get these patients better, and then maintain remission and keep them better. And we want to do it and get them off of steroids. This needs to be a steroid-free remission. Anybody on steroids, to me, is not in remission. Nowadays, though, we're taking our cue from the rheumatologist. We're talking much more about endoscopic remission, deep remission, the combination of clinical and endoscopic remission, because there's a decent amount of relatively indirect, although we're seeing more and more data every day, that those patients in endoscopic remission have better long-term outcomes, that there's data that this is associated with less hospitalizations, less complications, and less surgery rates. Obviously, if we can make our patients feel good and keep them out of the hospital and let them not have surgery, we're going to give them a better quality of life. Really, what we're talking about here is hopefully altering the natural history of inflammatory bowel disease. This is the traditional sort of step-up approach to inflammatory bowel disease. Start with the medications on the bottom that maybe don't work as well, but have less side effects. A couple of courses of that before you're seeing the corticosteroids, before you're seeing the immunomodulators, and people typically would save the strongest medications, the anti-TNFs, for last, and surgery was typically felt to be avoided until really necessary. I can tell you, particularly for Crohn's disease, we're really starting to talk about flipping this on its head, really not using aminosalicylates to treat Crohn's disease. Really, the mainstays of therapy now are steroids for induction if necessary, but really using the immunomodulators and the anti-TNFs. And as far as surgery is concerned, we don't want to be sending our patients to surgery if they need it, but you don't want to think of surgery as a failure of medical management. It's a viable and good option, and sometimes the worst complications we see are when we try to keep people out of the OR for too long. Ulcerative colitis still is more of an algorithmic, tends to be more of a step-up approach. Oral and rectal mesalamines for those patients with mild to moderate disease. In fact, topical or rectal mesalamine works better than oral mesalamine for left-sided disease, though most patients would prefer oral. The two together, the combination, actually works better than either one alone. Failing that, you'll typically use corticosteroids to induce remission. And I will mention now that within the last month, there's been a new drug approved for the treatment of mild to moderate ulcerative colitis for induction of remission. It's budesonide, MMX, so it's a special encapsulated budesonide that gets to the colon. We're used to using Entocort for right-sided colonic and ileal Crohn's disease. This is now formulated for the colon. Obviously, prednisone, once they require one or more courses of corticosteroids, typically we're using the thiopurines to maintain remission. Anti-TNFs, the two approved are infliximab and adalimumab, can be used if you need to avoid corticosteroids for any particular reason. They can be used in lieu of azathioprine, or they can be used when patients fail the thiopurines. For patients with very severe disease failing oral corticosteroids, those patients basically will end up hospitalized, intravenous corticosteroids. For the 1/3 of patients that don't respond to intravenous corticosteroids, you're talking about intravenous cyclosporin or infliximab or surgery. The therapy for Crohn's disease is more complex, and we talk about it more. It's more debated. You can see here all the medications that are used, and 5-ASAs are still probably one of the more commonly used medications for Crohn's disease, although I'll show you that we're trying to get away from that. The other thing you always have to think about when you're talking about treating Crohn's and ulcerative colitis is inducing remission and maintaining remission, and which drugs do which, because some induce remission but don't maintain remission, and others have too slow an onset of action to really induce remission. So mesalamines, they're very safe, they're well tolerated, they work fantastic for ulcerative colitis. There's really no good evidence they work for Crohn's disease, and according to recent guidelines, both in Europe and America, they're not recommended for Crohn's disease. What should we be aware of? That there is about 5% of patients that will have a rare paradoxical response to 5-ASAs, where their diarrhea, abdominal pain, bleeding can get worse, and there's a rare interstitial nephritis and renal dysfunction, so we tend to monitor the patients yearly with BUN creatinine and urinalysis. Okay, antibiotics. For the actual treatment of inflammatory Crohn's disease, again, there's really no good evidence-based medicine. We do use them for perianal disease, and we do use them for the suppurative complications, phlegma and internal abscesses. Corticosteroids have been the mainstay of treatment for induction of remission. They work very well to induce remission. That being said, there is zero data that they maintain remission, and of any of the drugs we're going to talk about today, and I tell my patients the same thing, these have the worst side effects. Okay? Prednisone and any systemic steroids, I think, are the most dangerous drugs that we tend to use. Entocort, budesonide EC, safer, but only for ileal and right-sided disease. Anytime you put someone on steroids, you should have a thought, what am I going to do to get them off steroids? Oftentimes that's either the thiopurines, which we'll talk about now, or anti-TNFs. So azathioprine, you can see here, if you put someone on steroids, you can follow that dotted red line down, by about a year, everybody that you put on steroids has basically had a flare. If you put them on azathioprine, you're doing a bit better with less than 40% of patients, or with about 40% of patients at that point. What are the issues? It doesn't work particularly quickly, and again, it has potential side effects that we need to be aware about and we need to monitor for. Pancreatitis or an allergy, that's typically going to happen within the first 2 weeks, almost always within the first 6 weeks. Continually, you want to monitor CBC and liver function tests, or typically transaminases, to look for bone marrow suppression or hepatotoxicity. These patients are at a slight increased risk for infection, typically viral infections, although we can see any infection, and they do have a higher risk of non-Hodgkin's lymphoma. General population, I'll typically quote about 1 out of 10,000 risk. With a thiopurine, you're talking about a 4 to 5 out of 10,000 risk. Non-melanoma skin cancers have also been shown recently to be more common in patients with on thiopurines, as well as abnormal pap smears, but not necessarily cervical cancers. But every 3 months, as long as you're on the drug, you need to have a CBC and LFTs. Methotrexate, I won't talk on too much, pretty similar to the thiopurines, except these are contraindicated in pregnancy. These are category X in pregnancy, so I tend not to use them in my young women who are contemplating pregnancy in the next few years. They still require close monitoring, high risk of infection. The anti-TNFs, more so than any other drug, have really revolutionized how we treat and think about inflammatory bowel disease, particularly Crohn's disease. This was the sort of seminal article back in 1997, the original trial, where they took patients with moderate to severe Crohn's disease, refractory to other therapies, prednisone, thiopurines, 5-aminosalicylase, and they got half the patients to go into remission, which was amazing. I'm not going to bore you with all the trials, but since then there have been many trials looking at infliximab, an anti-TNF inhibitor, effective for moderate to severe Crohn's disease, works particularly well with perianal fistulizing disease, moderate to severe ulcerative colitis, pediatric approvals now, smaller studies regarding the extraintestinals, particularly erythema nodosum and uveitis. They've been shown to decrease steroid needs, improve quality of life, and there have been studies suggesting that we can actually start seeing natural history development with less hospitalizations and surgeries. This is not a panacea. If you want to look at it glass half empty, if you start somebody on an anti-TNF at a year, maybe a quarter of the patients are in remission and off steroids. This is my favorite IBD study. This is a comparative effectiveness research study, not comparing a drug to placebo, but comparing different ways of treating patients. To be honest, I think this is how all studies should be done these days. This study took patients with moderate to severe Crohn's disease, randomized them to either azathioprine and placebo, infliximab and placebo, or the combination of infliximab and azathioprine. And you can see here at 26 weeks, patients with infliximab did better than the patients that got azathioprine, and the patients that got combination did better than either group. This held out to 52 weeks, and if you looked at this in mucosal healing, you'll see a very similar stepwise improvement. There are now 3 drugs for Crohn's disease for the anti-TNF, infliximab, adalimumab, and certolizumab pegol. 2 of those, the first 2 are also approved for ulcerative colitis. Efficacy appears same. Toxicity, which we'll talk about, appears the same. They really differ by how you give them, whether it's intravenous, subcutaneous every 2 weeks, or subcutaneous every month. As with anything that modulates the immune system, the biggest thing we worry about is infection. Any ongoing infection is really a contraindication to using these medications. They need to be screened for tuberculosis prior to initiation of therapy. They need to be screened for hepatitis B prior to initiation of therapy. There have been cases of fulminant hepatic failure. It's a little bit unclear whether these patients on monotherapy with anti-TNF are increased risk of lymphoma. It is clear that patients exposed to thiopurines and anti-TNF are probably at a slightly higher risk of lymphoma than just those exposed to thiopurine alone. Melanoma in a recent study was shown to be more common, so for any of my patients on a biologic or an immunomodulator, they're told to go to the dermatologist yearly. Some rare things we won't touch on, and all these drugs, because they are biologic and not, even if they're human, they're not that human, you can develop antibodies to these drugs. Natalizumab, more commonly used for MS, is used and approved for Crohn's disease. It is a selective adhesion molecule inhibitor. It basically blocks inflammatory cells from getting out of the bloodstream. It's effective for inducing and maintaining remission in patients with moderate to severe Crohn's disease, and it's particularly effective in those that have already failed anti-TNFs. Why aren't we seeing more patients on this? What's the issue? That early on, there were 3 cases of progressive multifocal leukoencephalopathy that were seen. It was voluntarily taken off the market in 2005. It was then brought back on the market first for MS and then for Crohn's disease, approved for monotherapy only, and these patients need to be closely monitored. Recently, there's a new serum test for JC virus antibody that actually helps us risk stratify the patients. So if a patient has not been exposed to JC virus antibody, their risk for developing PML is theoretically 0. but you still follow the JC virus antibody as they're being treated. If they've been exposed to JC virus antibody, which half the people have, the risk of PML is, after 2 years on drug, is close to about 1 in 125, which for a disease like PML is too high. Unfortunately, regardless of our medical therapies, up to 80% of Crohn's and 20% of UC patients are going to require surgery. For what? Either failure of medical therapy or complications, both for Crohn's disease and ulcerative colitis.
So great. Before you get into surgery, there's a couple of very interesting questions from the audience. So Barbara Fleming is asking, would you comment on the role of probiotics and fecal transplants in patients with inflammatory bowel disease?
Sure. The probiotics have been best studied for ulcerative colitis. There's one study in adults and another study in pediatric ulcerative colitis that VSL number 3 in very high doses can be effective for ulcerative colitis, mild to moderate. We're really talking about 1 or 2 double-strength sachets twice a day to induce remission, and then 1 double-strength sachet twice a day to maintain remission. For Crohn's disease, there's really no good data that they're effective. As far as fecal transplants, really it's experimental. There was one study that literally just came out in the pediatric literature suggesting it may be effective. And it's now going to be studied we'll be studying it as well as University of Chicago. A number of centers are now going to be looking very closely at fecal transplants for ulcerative colitis and Crohn's disease. Clearly, the best data for that is in C. difficile.
What about lifestyle? Exercise, relaxation response, meditation, biofeedback?
It's good for everybody.
Good for everybody.
I tell all my patients that there is data that stress, life stressors, meta-analysis suggests that it can affect the course of Crohn's disease and ulcerative colitis. It clearly exacerbates their concomitant IBS, which about 30% of the patients will have. I recommend exercise, I recommend stress reduction, whatever they can do to sort of better their lives. I think it's good for any chronic disease, whether IBD or otherwise.
Nicotine gum?
So with ulcerative colitis, I mentioned that smoking is protective. So it's sad, but some people who quit smoking will then go on to develop bloody diarrhea and get ulcerative colitis. They've looked at nicotine, they've looked at nicotine enemas, they've looked at nicotine patches. Open label studies suggest it helps. When you get down to the randomized placebo-controlled trials, no good evidence that it works.
You know what Sir William Osler said about that? He said the best time to use a new drug is right away while it's still working.
That's right. All right, so we touched on surgery. The reasons for it are up there. Oftentimes now it's failure of medical therapy. In Crohn's disease, it's really strictures and abscesses. And particularly in Crohn's disease, you want to be sure, because we're using all these effective, albeit potentially toxic medications, that what you're treating is active Crohn's disease, that it's not a stricture that's not going to get better unless you do surgery, that it's not a concomitant irritable bowel or bile salt malabsorption or something else. It's an exciting time to be treating inflammatory bowel disease. Really, what we do and how we do it is evolving. Each meeting we talk about this. Should we be going beyond clinical remission? Should we be aiming for deep remission? That's a big topic. Unfortunately, as good as our drugs are, we're really not able to obtain deep remission in more than probably half of our patients. When we're talking about the anti-TNFs, we're talking about potentially treating to drug levels. Drug levels are available. What are the optimal treatment strategies for our patients? We talked about top-down. Should we be using these more effective therapies earlier? Should we be using more combination therapy, combination of an immunomodulator and an anti-TNF? Who should we be doing it in? Really what we want to figure out is when a patient presents, are they going to have an aggressive course of Crohn's disease, and are we better by treating them earlier and more aggressively? More personalized medication using different clinical factors, perhaps some serologic markers, and hopefully eventually some genetics. We are doing that, I would say, on a daily basis. We're really trying to get better about risk stratifying our patients. And again, the biggest question is, can we alter the natural history of the disease? Can we get that risk of surgery in both diseases down? So there are many drugs and many ongoing trials in both Crohn's disease and ulcerative colitis. Golimumab is another anti-TNF being studied. Ustekinumab is an anti-IL-12/23 currently approved for psoriasis, currently in study for Crohn's disease. Vedolizumab is one of the more exciting drugs, I think. It's another selective adhesion molecule inhibitor, but this one blocks alpha-4 beta-7, so it's specific for the gut. So at least theoretically, we shouldn't be seeing the risk of PML, and there's good data that this appears to work both in ulcerative colitis and Crohn's disease. Someone will ask about it, so I'll mention Chicurus suis, which is the pig whipworm. Studies ongoing for Crohn's disease and ulcerative colitis. Rifaximin is a non-absorbed antibiotic. There was a recent study that suggests it may be effective for more moderate Crohn's disease. And up there I have the fecal transplant, which again, there will be studies that will be started up and ongoing soon. Want me to summarize? You want to ask me? All right, so we'll summarize. Ulcerative colitis affects only the colon. It's mucosal, starts in the rectum, and moves more proximally, whereas Crohn's disease can affect anywhere from the mouth to the anus. It is transmural, and it's characterized by skip lesions. If we can, try to avoid NSAIDs because we don't know so much about what causes flares of IBD. This is one thing we do know. Remember to vaccinate your patients for preventable illness. Screen for osteopenia and osteoporosis, particularly patients that are either postmenopausal or exposed to corticosteroids. Don't forget to have your patients get their colon cancer surveillance. If they're doing well, they will not come and see us. We know for a fact that half our patients are not adherent to their medications, and even more so, I would guess, for their colon cancer surveillance. So that's something you guys will need to remind them about. Again, when assessing a sick patient, because they will often come to you first, don't assume that IBD is what's causing their symptoms. Rule out infection, rule out other diseases, appendicitis, you name it. We've had major advances in the last couple of decades on treating inflammatory bowel disease, say particularly the anti-TNFs. These medications come with more potential side effects that we need to be cognizant of and we need to monitor for. And as I mentioned, we're really becoming more aggressive with our medications earlier in the course of the disease, hoping that we will be able to alter the natural history of this disease. And I think in the next years, we're only going to become more aggressive with treating these patients earlier, and hopefully treating the right patients with more personalized medications and medicine.
Terrific. Couple of questions, and then I wanted to ask you a brief question. So here's a question from Dr. Gregory Nakopoulos. Please forgive me if I've mispronounced your name. But how soon would you start treatment for a patient that was first diagnosed with Crohn's disease after surgery for what was thought to be appendicitis? So it turned out not to be appendicitis, but ileal Crohn's, and when would you start the treatment?
So I think it depends on what they do at that surgery. Whether they open them up and say, uh-oh, this is Crohn's disease, and they close them back up, or whether when they open them up, they say, oh, it looks like Crohn's disease, let's take out that affected section. If they take out the affected bowel and there's no Crohn's elsewhere, really what you're talking about there is prophylaxis of recurrence of Crohn's disease, which is a whole talk in and of itself. And this type of patient, you would potentially consider putting them on a medication to prevent the recurrence of Crohn's disease. Unfortunately, the medications that do that best tend to be the anti-TNFs, some data for 6-MP as well. If there's disease left in and there's no suppurative complication at this time, I'm starting treatment right away.
Terrific. Question, if patients diagnosed as having primary sclerosing cholangitis, should they now be screened for IBD?
Yes. They
Okay.
should all have a colonoscopy if they haven't had one.
Terrific. How do you evaluate remission in Crohn's disease? What modality?
So it depends on what type of remission we're talking about. Clinical remission is, how are you doing? What are your symptoms? How many bowel movements are you having? Is it affecting your quality of life? That's clinical remission. When we're talking about endoscopic remission, obviously then we're talking about a colonoscopy. But again, with Crohn's disease, we also can potentially talk about radiologic remission. Should we be getting imaging studies on these patients, and should we be following markers of inflammation like C-reactive protein, fecal calprotectin, those types of things?
Adam, do you have a slide where you're polling, asking a question? Is it?
I'm not sure if I have my questions that I have at the end. I'm happy
okay,
to ask
yeah.
them, but I'm not sure if they did the
So
the
here we
polling.
go. It's showing up on my screen.
I'll do this. Is
Oh,
this
here
what
we
you
go.
want?
It's the same one, yeah.
So which of the following are characteristics of Crohn's disease and not ulcerative colitis? Small bowel involvement, fistulas, skip lesions, perianal involvement, rectal sparing, or all of the above?
Okay, so the responses are coming in, so we'll wait for a while, and then I'll share the, you tell us the right answer, and
do so. Pull it down, I can't see the bottom.
it might show up there. Let's see.
I assume most on the right, so I can see how many hit the right answer. That's not going. In any case, it looks like, based on this, most of you are correct in saying all of the above, that these are all characteristics of Crohn's disease. Yeah, almost. All right, next. Patients with inflammatory bowel disease are at risk for which of the following? Osteoporosis, colon cancer, ankylosing spondylitis, venous thrombosis, or all of the above? It looks like everyone's getting this one right. How long do you want me to give them?
Yeah, we have 5 minutes. Let's give them another 5 seconds.
Couple seconds? All right. I'll count down in my head. So I think
If after 5 seconds they haven't answered, they're guessing.
they're guessing. So I think just about everybody got it right. Again, the answer is all of the above, that patients with IBD are at higher risk for all of these. And in this one in particular, this goes both for Crohn's disease and ulcerative colitis. Side effects of IBD medications include bone marrow suppression, lymphoma, pancreatitis, infection, and PML, or all of the above. And I was nice I didn't ask you to name which medication causes which complication. You guys all got this one right. All of the above. Oh, those are my 3.
Okay, terrific. Thank you very much, Adam.
Thank you.
Terrific.
Always a pleasure.
We have time for another question, but I don't see any more questions. I mean, there are questions related to you guys. Are there going to be recorded webinar of this? Here's
Yes.
one that I see now. I have a small cadre of patients maintained on 5-ASA with colonic Crohn's disease only. What, if any, consensus is there with that therapy currently?
So I will admit it, so do I. Just the best data for use of 5-ASAs in Crohn's disease is actually sulfasalazine. So there is data from the Crohn's cooperative study that sulfasalazine is moderately effective for inducing remission in those patients with Crohn's colitis. There is no data that it maintains, there's no good data that it maintains remission, and there's no good data that any other 5-ASA is particularly good at inducing or maintaining remission. That being said, I've inherited a large practice where 5-ASAs were used, and it's hard to predict. Just because we don't have good data doesn't mean we don't have, that it doesn't work for some individualized patients with either more mild disease or, in worst possible scenario, we're talking about it's a very effective placebo. But I have had some patients who've either stopped it because they decided to become non-adherent, had symptoms, went back on it, and got better. So I think there probably is some potential small subset of patients with more mild, particularly Crohn's colitis, potentially those patients that may have an indeterminate colitis or maybe a more UC-like picture where 5-ASAs, I think, probably may be effective.
Okay, let's take one more question. Do you do IBD panel Prometheus or other and TPMP studies before starting Imuran?
I definitely do TPMT enzyme test before starting Imuran. I do the actual enzyme test or the phenotype, not the genotype. The only time you need to do genotype is if the patient's recently had a blood transfusion, as the phenotype or the enzyme is actually in the red blood cell. I find it more helpful to find out where they are, whether they're a high, low, or high, low, or intermediate metabolizer. Really the reason to do it is to pick up that 0.3% of the population that doesn't have the TPMT enzyme. They're at a very high risk for severe bone marrow suppression. The data is out whether I tend to use it also to determine my dose of sticks, my starting dose of the thiopurine, whether I'm going to start at the recommended dose of, for 6-MP, 1 to 1.5 milligrams per kilogram, for azathioprine 2 to 3 milligrams per kilogram, or whether I'm going to start on the low end of that, on the high end, or for 11% of patients that are TPMT intermediate, you actually start with a lower dose and follow them closely because they're also still at probably a slightly higher risk for bone marrow suppression if you use, certainly if you use the typical dose.
Perfect.
I don't use the Prometheus test that is supposed to help you determine whether it's Crohn's disease, ulcerative colitis, or not. I don't find that to be as effective.
Okay. Thank you so very much. I'd like to thank Shire, Vero Pharma Incorporated, UCB Inc., and Ferring Pharmaceuticals Inc. for their support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for the next session coming very shortly, A New Era in the Management of Hepatitis C with Dr. Nizam Aftal. My name is Dr. Chopra, and I want to thank you again for joining us.